Error. Electricity in line. Override accepted. Infusion initiated.
Welcome to the INS Infusion Room, the official podcast of the Infusion Nurses Society. In this podcast, we explore all things infusion therapy through a real-life conversation, covering the latest trends, new research, evolving standards, and key industry insights. Whether you're an experienced infusion nurse or new to the field, we aim to keep you informed and empowered with the knowledge to stay at the forefront of the profession. My name's Derek, and I'm your host. Let's dive in. Thanks again for joining another episode of the INS Infusion Room. Today we have Andrew Walker joining us as our expert guest. And today we're talking everything ultrasound. So ultrasound-guided PIVs and training programs associated with that. So welcome, Andrew. If you don't mind, introduce yourself and tell a little bit about your involvement with INS.
Hello, I'm Andrew Walker. I have been an INS member since 2018. I've maintained my CRNI certification through those years, as well as a couple other ones. I work in a rather unique position in the Unity Point Health Meritor System, which is based out of Iowa. We're part of their Madison, Wisconsin affiliate. We're kind of the periphery outside of their Iowa hospitals. And at my hospital, I get the privilege and pleasure of being the clinical practice leader of vascular access and infusion therapy. And I know it kind of sounds like a mouthful, but right now it's pretty much like the job of a clinical nursing specialist, very population-based, where I get to just focus on vascular access and infusion. And I also have the privilege of, I was accepted as a member of the board of directors of the secretary-treasurer to the Infusion Nurses Society, and I'm really looking forward to getting into this. I've already been part of some meetings, and it's just an honor and a privilege. This is something that I get to do and carry on the Infusion Nurses Society and be part of that standards on practice on a level that I didn't think I was going to be part of when I got my CRNI certification back in 2018.
Well,
therapy.
Yeah, and we talked before, it's a very unique opportunity that many organizations don't have this position. So you get to do a lot of really fun things within infusion and vascular access and really focus on the specialty as a whole. So thanks for your contributions and moving the needle. So we'll jump right into your work. You've done a lot of work with training with ultrasound-guided PIVs across different departments throughout your organization, from labor and delivery to pediatrics, emergency department. So I want to dive in a little bit more about that training program and really, compare that with the standards and how you're exceeding those metrics. So if you don't mind, can you start by what inspired you to start champion for nurses to use ultrasound at the bedside?
Yeah, I'd be happy to. I have to correct you, but we don't have a pediatric unit we don't have an inpatient pediatric unit at this hospital, but we do see peds in our emergency room.
Perfect.
So most of the hospital is a mid-sized hospital with a total bed census of about 448. We have a big birthing center here. We do have a NICU, which I honestly don't do a lot up there. They have their own CNSs up there that do stuff. And I really got interested in doing ultrasound IVs back in, I think it was 2014-ish, where I was invited to become a PIC nurse at the hospital and join that group. And we had some BD reps come in training us on a new product. And working with an ultrasound. So I learned how to do ultrasound IVs on a teeny tiny screen with an 18 gauge, 10 centimeter long midline product. So I got to take that and run with it. And we started just placing IVs on these difficult patients. We were always calling anesthesia. This was 10 years ago. And I was doing this as a staff nurse and it was working out really well. And we kind of fine-tuned it and got in different size catheters and covers and everything. And then the CNS at the time, who was covering our vascular access team, said, are you guys doing this? We said, yeah. Do you have a policy for this? And we said, no. Well, they asked me to write one. So I wrote the policy for the procedure and the protocol. And then proceeded to finish training up the rest of our PIC nurses who were not ultrasound IV trained. They were using needle guides on their PIC insertions. So we trained up the rest of them. And then through the years, we trained up a lot of our float pool nurses. And then the model was working really well. And the training it's a little intense. We kind of pride ourselves on the intensity of the training. And it is it's one-on-one for about 3 8-hour shifts. So the whole process works really well of having a sit down, and it was always a PIC nurse or a vascular access nurse that was doing the training. Me and there's 10 of us here at my hospital that insert PIC lines, nurses that insert PICs, including myself. And then we have 3 people on our team that really like to do the training. So we only have PIC nurses do this training right now. We are looking into trainer programs on units that have been doing it for several years now. And then we started branching out into other areas of the hospital probably 5 years ago, especially in our emergency room, where our emergency room technicians place the majority of the IVs in the hospital. And when I go back and run the data on it, and some of these nurses will some of these techs will place 1,000 IVs a year. 1,000 IVs a year. So it made only sense that when they would call us for assistance, that we would get them trained up first because they have the highest volume. And then after that, we started running numbers in like our procedural areas and like how often we would go place an IV. So we kind of had these like anecdotal thresholds. We're like, okay, 22, 25%, we're doing 25% of your IVs. We're going to start getting guys trained up. So then we did. In some of these units, like we don't ever get calls from anymore, like our cardiac short stay unit. We rarely get calls from our emergency room now. And OB was a new one. Digestive health, we really get calls for that. And our infusion center was a big one. They see 70 patients a day right now, sometimes 80 patients a day. So we were doing like a quarter of their IVs. So we got a whole bunch of their nurses trained up about 4 years ago. And that's worked out really, really, really well. So when they give us a call and they say, hey, we're having some trouble, we know it's the real deal. So that's kind of how, sorry, Matt.
Yeah, I have a question for you. So, within the standards, it really emphasizes the comprehensive training and with a really special focus on competency assessment and continued assessment. So with your team training these nurses within these other areas, what does that look like? How do you ensure competency and then ongoing competency?
Initial competency is, like I said, it's 3 days one-on-one. And we start out, we do now biology, we understand the products, we understand the indications, we go over the policies, we go over the procedure, and then we have a competency developed that reflects our policy, our IV policy and the INS standards. Just really making sure that we're doing it, the indications for the IV in terms of, and we talk about depth, we talk about catheter length, we talk about catheter purchase inside of the vessel, we talk about catheter to vein ratio, we talk about what they're getting in there. So we have this whole long list of competency items that we discuss with the nurse. So once we talk about all that stuff, which is kind of an ongoing conversation through these 3 days, we will do gel block simulation. We have a menagerie of different gel blocks in different sizes and different depths, and we run through all of our different size needles, and we have everything from 24 gauge, 19 millimeters, all the way up to like 18, 16, 64 millimeter catheters. And we kind of really talk about the depth and the necessity of that line and the location of that line and what's running into that line. And is this the right line for the right reason, for the right patient, for the right infusion? Kind of like those 5 rights of infusion therapy, right? We want to make sure that those are all touched on. And then after that, we usually take our trainees down to our DHC clinic or our endoscopy unit, where it's elective, high volume IVs, very low, relatively low risk. The patients are usually pretty healthy, elective. And those are like what we call the training vessels. So once we show 5 to 10 very adequate insertions and understanding of needle guide or needle tip, and where your needle is and what it's doing and how to get into the vessel and what we're looking for in that walking it in technique, we'll go down there and start doing it on patients. And then over that 3 days, we optimally shoot for 20 to 25 insertions under supervision. And then we have that nurse, we round back with the manager and say, hey, put this person on like unit IV duty for like the next couple of weeks. And that seems to work really well. And then so that's like the initial...
I know you mentioned the walk-in technique, and I can appreciate that so much. My initial mentor and trainer, who was training me on ultrasound-guided PIVs back in the day, she was all about just looking for the indentation of the vessel with the needle. After that, she looked for flash drop, and she never walked it in, so she never really ensured that tip of that catheter was staying in the middle of that vessel. So talk a little bit of what is, if we have someone who's listening who's never heard walk it in, what is that? Can you explain that a little bit more?
So the walking it in technique, walking the needle into the vessel, once you identify your needle tip just above that vessel under your ultrasound and you get through that vein, and the walking it in technique is as you advance your needle through the skin into the vessel, and you slowly move your ultrasound probe forward so you're always at the tip of the needle. We don't want to be, we make it pretty clear in the training on what the difference is between the tip of that needle and the shaft of that needle and what the difference is. And we'll use kind of like our, your longitudinal approaches to show where your tip is, where you actually think when your shaft is actually there. And then, that white tip of the needle, and then that little teeny
headlight
dot above it, the back, the top back of the bevel.
Yeah.
We talk about that. We talk about, well, it's in the vessel, you don't have a blood return, and then they'll feel that pop, or they'll see the spring back on the ultrasound, and they're like, oh, now I got a blood return. I'm like, that is what we want to see. Now we're going to walk that in just a little bit further to make sure that catheter is going to, the needle is in there before we cannulate. And before we talk about that, we always make sure we talk about that we scan ahead. We do lots of pre-scans to make sure where your catheter is terminating before you cannulate, because we don't want to cannulate through a bifurcation. We don't want to cannulate if there's like a narrowing or a restricting of the vessel, if there's like a weird curve to it, because veins do all sorts of weird things, and they're not these perfectly straight static tubes like we think they are.
Yeah, agreed. And after you learn that walk it in technique and you get that technique down, it's a game changer. Takes you from low statistical insertion, first time insertion, to very high. So I appreciate that. And I think another thing about ultrasound guided training, and you may be planning on touching all this, is really what to avoid. So is that part of your didactic? So we're identifying what we want to stick, but are we talking about what we don't want to stick as well?
Oh, absolutely. Even before we start playing with the gel blocks and inserting needles into gel blocks and that kind of simulation, we'll scan. I mean, I can pretty sure I can show you a picture of my vessels. If you show me an ultrasound screen of vessels, and I can tell you if it's my arm or not, because I've seen my own arm so much. And we show nurses what the difference are. So essentially, we use my arms in a lot of the training and how to position yourselves, how to hold your hands. And what we're looking for is we obviously want to make sure we're not cannulating arteries. We want to identify nerves. We identify muscles. We identify valves, definitely. Even that big bone on the ultrasound screen and your forearm bones. I always ask nurses, and they're like, I have no idea what that hard thing is in there with liquid in the middle. I'm like, it's a bone. And it's kind of like this giant aha moment, right? And I have them track vessels all the way from wrist all the way up to the upper arm. We do preach to avoid the upper arm if possible and kind of reach out to VAD if it's getting to that point. But I also have them trace nerves all the way up and down the arm so they understand how deep that nerve is, in the thicker part of a forearm down to your wrist where it's a little bit thinner, and how sometimes it can wrap around the artery, and our arteries are usually a little bit deeper than those, like the cephalic vein or the basilica in the back of the arm. So we do a lot of anatomical landmarking before we do gel block insertions. Definitely before we go put needles in people.
That's great. So talk about some of your challenges that you experienced whenever you implemented across the various departments within your organization.
A primary challenge was just, vascular access can do it. So I would have to show, it would have to take me like months of collecting data or running reports and showing managers on units saying, hey, just to let you know, your patient population is changing and we have this weird kind of relationship with another hospital in town. We have the joint operating agreement. So we were seeing a lot more dialysis patients through the years, a lot more difficult access patients, a lot more chronic issues. So I would be literally showing the managers this data, and like as the dialysis patient population would increase, so would the use of my team, until to the point where it's like, hey, let me give me 3 days with one of your staff. You have an ultrasound on the unit. The providers have already said we can borrow it. We can look into getting your own at some point. So initially, it was getting the provider or the managers on board to really let their nurses go for 3 days. And they're like, well, how about like 3 hours? And I'm like, no, not good enough. How about like 8 hours? And I'm like, no, not good enough. We want our nurses, we want our ultrasound IV trained nurses to come out of this program practicing at an incredibly high level, like 99% first time insertion rates. That's what we want. We don't want them calling us because they can't do it after 4 hours of training, after a classroom or an online module. We really wanted that 3 days. So that was a really big hurdle. And it was kind of hard for managers to stomach that cost initially, but now it's changed over the last 5 years, and they're very happy to invest that in their nurses.
Wonderful. And what did that do for your department, productivity-wise? Did you see a shift in skill set focus, or what? Did you see a decrease in your starts? Talk about that.
No, actually, we did not see a decrease in our starts. We keep seeing an
Okay.
increase in our starts. In our adult inpatient units, about 50% of the IVs get placed by an ultrasound. And it's so our adult inpatient census is usually 160 to 180 a day. That's not including the North Wing or obstetric units. I say North Wing, it's what it is here, but it's labor and delivery, it's OB triage, it's postpartum, antepartum. So just in our adult inpatient right now, we're running 50 to 55% ultrasound-guided IVs.
Is that clinician preference? Are they automatically starting with the ultrasound, or are they escalating?
Sometimes we are starting right away with the ultrasound.
Okay, good.
We've kind of done a lot of educating through the years at unit-based councils and at staff meetings. And if you can't see a vessel and if you can't feel a vessel, you probably shouldn't be putting anything in that person's arm. And we're actually just rolling out a
Amen
tool
to
right
that.
now that we're trying to integrate into our electronic charting software, where we're trying to integrate that a Divas scale into like an IV consult order, which we already have.
Yeah.
So we've kind of preached a lot about this. And it's really, with our patient population, a lot of chronically ill, a lot of like IV drug use, a lot of renal failure. We get these great opportunities to really shine on the ultrasound and get our procedural units, like our outpatient procedural units. Most of the patients are pretty healthy and usually younger. And mostly at times the nurses down there have no problem getting IV, but it's these chronically ill people that really need that specialized, and nurses are kind of trained to identify those patients.
Absolutely. And we talk about escalation of care. I think that there's a misconception within this, how people interpret the standards when we talk escalation of care. A lot of people read the standards in regards to the 2-attempt rule, and they think that they have to try 2 times before they escalate care to a more advanced clinician or additional tools. But that's not what the standard's intent was with that particular standard, what it was addressing. What it was saying is no more than 2 attempts. So if you feel like you can achieve and be successful within your first attempt, maybe even a second attempt, but nothing past the 2 attempts. So in reverse, it's not addressing that you have to attempt twice. And I think a lot of nurses are under that assumption, or if they do escalate care, they have heard that conversation. Did you attempt? So talk about that. What's your views on that?
Before I got a hold of our policies, that was clearly written that nurses are required to try twice before calling for help on it. And I changed that. I removed that because I was aware of that standard. And some of our older nurses really like to make a valid attempt if they can see a vessel and if they can palpate a vessel. And a lot of these, the newer nurses that we're getting out of the last 5-6 years, they're not going to go to try to do something if they don't feel like they can get it the first time. So we really do appreciate that escalation to our vascular access team, and we have our PRN nurses that flow with us that are kind of like nurse floaters throughout the hospital, and we have most of them ultrasound trained up too. So it'll usually escalate to the PRN nurse, and then it will escalate to vascular access if they're having problems.
Okay, cool. So what kind of metrics do you monitor to ensure that you have efficiency and you keep your statistics good within your departments?
So we monitor, number one, we monitor the volume of ultrasound IVs by units over time. And like I said, right now we're running 55%. 2 years ago, we were running 35, 40% on units. 5 years ago, we were running, 10 to 15% on units. And within all of that, we can look at insertions by inserter. We can look at the number of documented attempts by inserter. We can look at infiltration rates, phlebitis rates, essentially anything that's documented in our electronic health system. I have reporting functionality built into it, so we can slice and dice. Like I have right now, have our last month's worth of IV data up right now. So we can essentially run insertion attempts, infiltration rates by person, by location, by catheter size. It's not something we do often, but we can, especially if we hear that there's some issues. We see incident reports where, somebody files an incident report because IVs are infiltrating at a crazy rate and There's the incident reports that we use for those, and then there's the actual documented data that we use to assess those. We can kind of compare them. Those are the kind of metrics that we track informally. Formally, we do track volumes by ultrasound and attempts. And a lot of that information, especially the volume, gets sent out to managers about once a year.
Okay.
And we also use that in terms of for competency tracking as well.
Great. If you have new nurses, is it automatically something that they learn, a skill they learn, or is it after they've been there for some time? How do you manage that as new people on board?
So new nurses, for the most part, don't learn ultrasound IV training. I don't pick the nurses. I leave that up to the unit managers to decide who's going to be next. And what they really want to do with that is what we've encouraged them to do is not train up the people who, number one, really want to do it. So it's not mandatory. It is a non-mandatory training. And then the expectation is that you are a unit resource to help out your staff. So we will often ask, hey, did you check with your unit-based person? Do they have time to come and take a look before we get involved? So I really leave it up to the managers, and then I really encourage the managers to spread that skill out over as much of the staffing as possible, because we don't want all the ultrasound trained people on day shift, because we have got a good pick team here on day shift. So we really aim for like weekends and nights when we don't have, especially on nights where we don't have a pick nurse or vascular access nurse here. We have some ultrasound trained float staff around, but resources kind of dwindle on nights, and we're trying to bolster up that resource on nights. So we really leave it up to the managers to decide and ask and partner with the staff on understanding that they're going to be a unit-based resource and people are going to reach out to them.
Okay. So we're going to try something new. We've not done this in the INS Infusion Room, but we're going to start... We're going to go into a segment. It's the listener engagement segment. And since we're talking vascular access, we're going to label this access success. So I'm going to give you 3 rapid fire scenarios involving difficult IV access. For each one of these, I'm going to give you 20 seconds to tell us your go-to strategy using ultrasound guidance. Are you ready?
I'll try my best.
All right. So I'm going to go ahead and start the clock. And actually, I'll ask you the question, and then I'll start the clock for 20 seconds. So scenario 1, a pediatric patient with a history of frequent venipuncture and tiny veins. What's your go-to strategy? Go.
My go-to strategy would be, number one, we don't have an inpatient pediatric unit. So this patient would present to the emergency room, and our emergency room technicians are very skilled at ultrasound IV and understand the techniques to put an IV in a child, such as like the busy bee, and they use distraction, and they use our child life specialists and stuff. And sometimes they just got to pin them down. I know it sounds awful.
All right, stop. Perfect. Okay, so scenario 2, an adult with obesity and non-palpable veins. Go.
The staff nurse will just call vascular access for this one. They can't see anything. They can't feel anything. And we're going to walk in, and we're not even going to look. We're just going to scrub that forearm for 30 seconds, and then we'll suit up our probe cover, and we'll probably go with a 20 gauge 48 millimeter.
All right, thank you. And the last scenario, an older adult with fragile scarred vessels from previous infusions. Go.
The nurse would probably give us a call again for this one if they have scarred vessels and lots of previous infusions. We would give them a good scanning in both upper extremities, see which ones are good compressible, making sure that a lot of those vessels are compressible. Those compressible small ones, we would obviously use a smaller gauge catheter, even down to a 24 gauge catheter. We have some longer ones that we like to use.
All right, time. You did pretty good at that, Andrew. I'll tell you, you've thought through these a few times, maybe. Like you think quickly. It's like you have some experience within the clinical realm.
Well, as much as my time I spend in office, I still get to see a lot of patients and put a lot of needles in people and consult with my team on these difficult cases, and it's been great.
All right. Well, fantastic insights, Andrew. Do you have any final thoughts before we wrap up today's episode?
My final thoughts are, as I read a lot of the literature and I read all these publications through all the various journals, on places getting their IV teams up and running, to the executive leadership of these hospitals, it is absolutely worth the investment to find the nurses in their hospital that want to do this and really invest in them and help them grow in this skill, because they will take your hospital and they will take your patients to places that your hospital hasn't been before.
Well, thank you for that. So thank you for joining us today and being on the INS Infusion Room. As always, I'm your host, Derek Fox, and it's been a pleasure sharing this important discussion with you. Remember, knowledge empowers us to make informed decisions. Until next time, stay informed, stay curious, and keep gaining knowledge. Thank you for tuning in.
Infusion complete.